This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to another episode of Beauchamp from Pittsburgh. I am still your host, Dr. Tony Tarchichi. Just for those of you who are new, I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh. We've been doing this podcast now since October of 2016, where we review different topics for PHM based on the American Board of Pediatric Content Specifications. We have an interesting one today. Now, I've been trying to figure out how to cover ethics on the podcast. For those of you who don't know, ethics is part of the American Board of Pediatric Content Specifications for pediatric hospital medicine. It's roughly 2%, and it's ethics, legal issues, and human rights. And I wanted to kind of do it in a way to tie in contemporary issues to talk about them both. I was lucky enough that this LA Times article called "Some Vaccine Experts Question Rush to Give Kids COVID Shots" from June 2021 popped up, and I read it, and it gave me an idea, and I'm hoping this works. So what we're going to do today is a little different. We're going to talk about vaccination in kids, but we're going to talk about it from two perspectives. We're going to talk about it from the perspective of the science. We're going to review what COVID, the morbidity and mortality of COVID in kids worldwide, and I'm hoping nationally as well, and hospitalizations and MISC. And we're going to review side effects of the vaccine that we know of up to this point in kids, the prevalence and how severe are they. And then we're going to talk about ethically what ethical questions we should be asking. Because there's a lot of noise on all the news channels about should we or shouldn't we be vaccinating kids. And I'd like to talk about it from an ethics perspective and a science perspective to kind of do it right. So for that, I needed two expert guests, and I was very, very fortunate. Our first guest I'm going to introduce to you is first time on the podcast. He's our ethics expert. So I'm going to introduce Dr. Armand H. Matheny Antommaria. He's a director of the Ethics Center, the Lee Alt Carter Chair of Pediatric Ethics, and professor in the Division of Hospital Medicine at Cincinnati Children's Hospital Medical Center. Armand grew up in Pittsburgh, received his medical degree from Washington University School of Medicine in St. Louis, and his Ph.D. in religious ethics from the University of Chicago Divinity School. He completed his pediatric residency at the University of Utah. His research focuses on a variety of issues in pediatric clinical ethics, including ventilator triage and mandatory vaccine programs. And he has served on the American Academy of Pediatrics Committee on Bioethics and is an associate editor of Pediatrics. So first, Armand, welcome to the podcast. Thank you for joining us.
Oh, it's my pleasure.
And our second guest almost needs no introduction. Is a regular guest on the podcast, friend of the podcast, Dr. Andrew Nowalk. Dr. Nowalk is an associate professor of pediatrics and clinical director in the Division of Infectious Disease in the Department of Pediatrics here at UPMC Children's Hospital of Pittsburgh and the University of Pittsburgh School of Medicine. He's a 1999 graduate of the MD Ph.D. program at the School of Medicine. He completed pediatric residency and infectious disease fellowship training at Children's before joining the faculty of the School of Medicine in 2005. He maintains clinical practice and an active research program in Lyme disease and serves as co-program director of the pediatric residency program. And he's participated in data science research in diverse areas, including management and diagnosis of the febrile and hypothermic infant. Andy, welcome back.
Tony, thanks for the continuing invitations.
My pleasure. Okay, we have to do our conflict of interest disclosure statement. I will go first, kick it out to Armand, and kick it out to Andy. I have nothing to disclose relevant to this podcast.
I have nothing to disclose relevant to this podcast either.
No, I have no potential conflicts of interest related to this topic.
So let's start first with some of the infectious disease information. Andy, would you mind describing to us the effect COVID has had on children? And we're going to define children here as anyone under 18 years of old. So we want to know about mortality. What do we know about morbidity, like any long-haul COVID in kids or other issues? And data on how well or poor COVID is passed in schools. We'll start with that.
So I think that this is really important data to use when we're talking about the risks of vaccines and the benefits of vaccines. So what do we know about COVID in children? One of the things that really upsets me a little bit when I read these opinion articles is the automatic assumption that COVID has been harmless in children. And you see this including in the article we're about to talk about, an almost implicit bias that there is really nothing to fear with COVID in children. So far in the United States, we've had more than 3 million reported cases of COVID in children. So that's a fairly large chunk of all of the children in the United States. Remember that reported cases obviously lag actual cases because of milder cases in children overall. But I get a little upset when people say it's benign in children, in that there are almost 500 reported deaths in children due to COVID since the beginning of the pandemic. And just to give you a ruler of why that upsets me, the CDC just began really specifically tracking deaths from influenza, which we routinely vaccinate all children against, in 2009 with the H1N1 pandemic. And in a bad pandemic flu year, we will have a couple of hundred deaths in children. So COVID has caused significantly more infections in children and significantly more death in children than our worst influenza seasons. So I would say that from my point of view as a pediatric infectious disease expert, COVID is a big deal in children. I'm thankful that, the mortality rate per case is very low. When you look at overall mortality from COVID in children, it's less than 0.1% of cases. And if you compare that to, for example, 80-year-old and above in the United States, the case fatality is more than 25%. So it clearly is a much, much, much more benign disease in children, but it's very transmissible, and it has caused deaths and hospitalizations around the country. And I'm not even going to touch the subject of MIS-C. And MIS-C has led to further deaths in children and a lot of hospitalizations. And I think, Tony, probably in the, spring of this year, we were seeing as many MIS-C hospitalizations of children as we were seeing acute COVID hospitalizations. So clearly a very impactful disease in children, though thankfully not the routinely fatal infection we saw in older adults. So when you think about COVID in schools, schools are a place where certainly COVID can be transmitted. We know from advancing research that the airborne route is important, especially in indoor spaces with poor ventilation. So that's a fact. And we know that children are really good at transmitting any respiratory virus to each other in school. And as a highlight of how confusing and controversial that is, just take this week when the CDC announced that they think unvaccinated children and vaccinated children and teachers can go back to schools without wearing masks. And then the American Academy of Pediatrics came out in the same week and said, no, actually, we think everybody should be masked in schools. So it is controversial data, and exactly what you should do with it is challenging. But it is clear COVID's been important in children and has caused a lot of pediatric deaths.
And to round out the discussion, do we know anything about the Delta or Lambda variant? Has it changed anything, whether in mortality or transmissibility in kids, or is it still too early?
We don't have any specific data from children, but I think the data is pretty settled that the Delta variant is more transmissible than the Alpha variant. And, the Delta variant it started in India. The Alpha variant started in the UK, and both of them are more transmissible than the main clone that circulated around the United States. The data about how severe it is has been hard to suss out, but it's pretty clear now, after some good studies from the European literature, that it is not more severe. So it's probably about as severe as all of the other strains that we've seen circulating around, but definitely more transmissible. And so, it's automatically more severe if it's more transmissible, because you can infect more people more efficiently, and therefore you're going to put more people in the hospital. And since some percentage of them will always have a bad outcome, it's more dangerous by that measure intrinsically.
And then just to be transparent about everything, we know the pandemic itself has increased kids' mental health issues and specifically overdosing of drug use and eating disorders. That we think has been a side effect of the quarantine and the isolation, not so much the virus itself, but the downstream effects of our response to the virus. And then, Andy, could you talk a little bit about the vaccine side effects and specifically talking about myocarditis, which has gotten a lot of press?
Sure. And I think this is, first of all, a tribute to the fact that for anyone listening to this, the intensity of monitoring for effects and the transparency of discussing them. I think we had a case study with the, sinus thromboses events in older people with the J&J vaccine. And now we have a great case study with myocarditis and pericarditis in kids. The most recent data, there's a couple of hundred cases of it that we've seen in children. Thankfully, it has been fairly mild in that these kids have, for the most part, needed only supportive care and have had spontaneous resolution of the inflammation. It's been tracked pretty carefully and we're all looking for it, but it's thankfully, it does appear to be a fairly mild side effect. It seems to be much more associated with the RNA-based vaccines, much more so than J&J.
Is there any other side effects that are standing out as coming up more often for the vaccine in kids?
No, I mean, they're seeing what we see with adults, and that a lot of people feel really lousy for a day after they get this vaccine. It is worse than a normal flu shot. It's not quite as bad as the new varicella vaccine for adults, but just the tidbit, as you well know, because I told you this on another podcast, when we gave it all to our residents in about a 3-day period, about 25% of them had to miss work because they felt really poorly. And then every single one of them came back the day after.
Okay. Now, Armand, before we turn to you for our ethics questions, are there any questions about the vaccine or the virus itself that you have for Andy that I didn't ask?
No, I think you covered everything very well.
Thank you. So
I think that's good because I don't have any ethics questions for Armand. I'm really going to sit here and learn because I think, Tony, compliments to you. This is a really fascinating field, and as an infectious disease doctor, not to steal the floor from you, but we're struggling with these conversations. And I think that folks like Armand hopefully can help us think this through as we're talking to our patients about this really critical intervention.
Well, that's a great intro, Andy, and you stole it, but you did a nice job with it. So, Armand, what ethical questions should we be discussing or thinking about? And then could you define the concepts themselves, if possible?
So can I highlight two separate issues? One is the process of age de-escalation in the study of the safety and efficacy of the vaccines, and why we're in the situation that vaccines are available under the emergency use authorizations for individuals above 12, but not younger children. And then talk about the evaluation of vaccines both as a individual preventive measure, but as a broader public health measure and the ethics related to that. Would that be okay?
Yeah.
So it's important to say that because children don't have the same capacity to consent as adults, in novel therapeutics, it's generally standard to undergo age de-escalation, to demonstrate that the intervention is safe and effective in adults who are able to give informed consent, and then gradually go into younger age groups if it proves safe and effective in the adult population. So you saw, initially an EUA for individuals over 18. Now the authorization for the Pfizer-BioNTech vaccine in individuals over 12, and then ongoing studies in younger age groups. And the exception to that would be conditions that are prevalent and life-threatening in children. So you can think of, say, SMA or cystic fibrosis. In those cases, it would be reasonable to start out doing studies in a pediatric age group. But otherwise, this kind of age de-escalation approach is appropriate.
And so just to make sure I understand that, because I'm not going to lie to you, ethics is not my strongest suit. So what we're saying is in a pandemic like this where people are affected all broadly across all ages, the ethical thing to do is to start research in adults who can give consent and understand, and then slowly go down, as we've done, initially all adults, then 12 to 18, and now studies are undergoing for under 12.
Yep. And I would say that that's not just in a pandemic situation. I would say in other situations that's appropriate too. But that's why we're in the situation of only having an EUA for a subset of our pediatric patients.
Okay.
And then as people think about vaccination, I think it's important to think about vaccines both as a preventive measure for individuals and then as a public health measure to benefit society. And that parents are potentially making decisions about, as a preventive health measure, the relative risks and benefits of the vaccine for their individual child. And I would say that I agree with Andy that the current data would suggest that the risks and benefits for a given individual are favorable to become vaccinated. I think it'll be an interesting question over time whether the side effect profiles in different patient populations vary. And say, for example, there might be a preference if you're a adolescent male to get the J&J vaccine because it has a higher risk of thrombosis and thrombocytopenia syndrome, but that's more prevalent in women than in men. And so it'll be interesting to see if there might be some preference in different populations based on the side effect profile.
So then the question that pops out, that constantly comes up, whether it's on other podcasts geared towards not physicians or in the TV or in the news, is, as Andy said, if the mortality rate's less than or around 0.1%, right, Andy?
It's actually less than that.
Less than 0.1%, which is very, very low. Is this ethically appropriate to be giving this vaccine to kids when the mRNA technology is so new for vaccinations? That's the question people keep throwing out. How do we begin approaching that?
So the purpose of the age de-escalation studies is to provide evidence of safety and efficacy. And the current studies in patients that are over 12, have demonstrated safety and efficacy for, Andy, you have to help me whether the EUA is both for the Pfizer-BioNTech and the Moderna or just for the Pfizer-BioNTech vaccine.
For right now, I think it's just Pfizer.
Okay. So there's demonstrated safety and efficacy of that particular vaccine in this specific age group. Even with adults, the populations that are studied are relatively limited, and that this ongoing monitoring system for rare or uncommon side effects. And adults are having to make that evaluation too. I think that people have to decide, when there's enough data. My general understanding is that vaccine side effects generally appear within 6 to 8 weeks. And so we're well past that window, so providing a high degree of confidence. I would say that to the extent that people are anxious about new technologies or newer technologies, I think the availability of things like the Johnson & Johnson vaccine that uses the adenovirus vector, once an EUA is approved for individuals over 12, would provide them an alternative if they weigh those risks and benefits differently.
So, Armand, it sounds to me, well, let me ask you this. In the ethicist community, is there a dilemma in terms of vaccinating younger kids as there seems to be in the lay press? Has this been talked about more? Is this something you all are discussing, or is it kind of universal, like this is a good idea?
My sense is that the current state of the conversation is about individual parents making decisions for their children. And so I don't know that this is fundamentally different than other decisions that parents make. I haven't seen the conversation advance to whether or not the COVID vaccine should be included within the mandatory vaccine schedules for school entry, in particular because either they're not an EUA for the appropriate age groups, or even for older, for adolescents, they're not licensed. I think that will be a question that comes up eventually, but isn't currently a topic of conversation. So the other part of it is then, thinking about vaccines as a public health intervention. And we have this ongoing debate about the existing vaccines. If, my child's at a relatively low risk of contracting measles, and I think that the risks of the vaccine outweigh the benefits of the vaccine because my child's at low risk of contracting the disease, is it okay not to immunize my child? And in that case, that's probably not an individual preventive decision. It's a public health decision that we mandate vaccination for school entry, not to protect individuals, but to protect the population. And I think that will be a question that may eventually be a question relative to the COVID vaccines, but I don't think we've started to see that discussion. Like we see it in bits and pieces in adults about whether or not workplaces or schools can require the vaccine. So the hospital in Texas that has a mandatory vaccine program that separated, I think, about 150 employees for not becoming vaccinated. And then the recent announcement of a federal court judge refusing to issue a temporary injunction against Indiana University's requirement for vaccination for most of its students and faculty. So we start to see that in the adult population, but we haven't, seen that move down into the pediatric population.
And are the ethical principles at play there? Is it one is autonomy, clearly. The patient has their autonomy. They feel like they can do what's best. What is the other one in terms of when we're studying ethics for our boards? What other ethical issue are we back and forth on?
Probably non-maleficence. So,
would you mind describing that a little bit?
Yeah. And so there are a variety of different approaches to ethics. One of the common ones that people use is the principle-based approach, or principlism, that developed out of Beauchamp and Childress' principles of bioethics, which emphasizes autonomy, beneficence, non-maleficence, and justice as four mid-level principles to guide decision-making. And I think that's a great place to start for many people. So autonomy is the ability to be self-governing or make decisions for oneself. So I should get to choose whether or not I'm vaccinated. The classic limit on autonomy or liberty is harm to others. And non-maleficence is preventing harm to others. So in this case, if you're not vaccinated, you might transmit the infection to other people. And so in that situation, non-maleficence might outweigh autonomy in order to, in particular, protect individuals who can't be vaccinated or can't be vaccinated effectively.
Now, you said that's one of the systems used. So I'm assuming, and again, I know very little about this, Armand, so please forgive the question. In the ethicist community, you guys have others that you use, and they may be more advanced than this, and that's what you're using to talk about this particular topic. Is that a fair assumption?
Wow, it's great to get to talk about ethical theory. So the thing about Beauchamp and Childress' approach is that they claim that it works for people who hold different high-level ethical theories. So if you're a deontologist, somebody who has a rule-based approach, or you're a utilitarian, somebody whose focus is on the outcomes, they would say that you could both agree to the importance of these four principles. Some people would disagree with that claim, or one of the issues with the principle-based approach is, well, how do you weigh and balance the principles? So, although in American culture, autonomy tends to have a high priority, they would say that none of the principles in and of themselves is more important than any of the others. But then you're left with the problem of, well, how do you specify the principles? And when they come into conflict, how do you decide which of them is most important? And so some people would argue that that leaves a pretty big gap in their system. And it is to say then that there are other approaches. So casuistry, or a approach that focuses on paradigmatic cases, and rather than takes a rule and tries to apply it to a problem, tries to argue from analogies from one case to another, would be a different approach. Or people taking narrative approaches, focusing on people's life plan and how decision making fits within that plan or not. So it's just to say that there are potentially some limitations to the principle-based approach, and that some people use other approaches in different contexts. But, I think for lots of people who are clinicians, the principle-based approach works really well and is a great place to start.
That was helpful. Thank you. Now, Andy, you're infectious disease. People are coming to you left and right for these types of questions. Did you have anything you wanted to ask about this? Because you do this more than I do. From an ethics perspective, what questions were you seeing? What did you want to know?
Well, I think that, where we've hit the wall, and I don't know that I'm going to struggle to phrase this as an ethical question, is really parent autonomy. And, we have a lot of parents who I think view this purely from an autonomy issue, where they don't want to consider this. And for me, it's complex in that I think that that's often wrapped up in very poor information that they're working from. As anybody who turns on a TV can tell you, it's the worst thing that ever happened to vaccination in the last 18 months is it's become politicized. And it's really, I have never thought that I would hate seeing vaccines discussed on news channels so much, but the fact that they're discussed on those news channels means they're part of the listing of contentious issues that people need to go through. Whereas I think that this is not, for me, a political issue at all. I think it is more about what Armand is describing in terms of balancing beneficence and autonomy. What gets lost a lot is that if we have a large chunk of the population that remains unvaccinated, it's always easy for the part of the population that remains unvaccinated but at low risk from a disease to feel comfortable in that. But the problem with infectious diseases is they do not have any set agreement to only infect those people. Those people almost always then walk next door to their 80-year-old grandparent and then become the agent of infecting those people and do cause harm. So that's, for me, where the ethical issues get a little murky. I recognize the importance of autonomy, but I also recognize that there's a very significant societal issue here that if we don't control the disease in an unvaccinated population, we will continue to kill a lot of people who are particularly susceptible, and not just on the adult end, but on our, immune compromised children as well. It's a thorny issue. I'd be interested, Armand, in kind of how you first of all, how you coherently translate that into an ethical discussion, which I am unable to do, and I'm glad to hear your thoughts on. But also, how do you at a societal level begin to have that discussion about what responsibility for beneficence do I have when my unvaccinated child could then be an agent that infects the rest of the community?
So I think that we've, as an American culture, have addressed that in part through the mandatory childhood vaccination programs. So many of the conditions for which there's childhood vaccination predominantly affect children, and that vaccination in childhood potentially confers long-lasting immunity, so that there are in all states, requirements for school entry, and so measles exists at a relatively low rate in the population because of that. The interesting thing is we don't have those types of programs for adults. So there's not a comparable requirement for adults to have pertussis boosters. And so we don't have that mechanism, particularly because we don't have that kind of cinch point of school entry that we can, enforce on most adults. And so part of the question would be, in order to protect society, would it be appropriate to have vaccine mandates for COVID, and what form should they take? And interestingly, in the U.S., we've chosen not to implement what are referred to as vaccine passports, which don't require vaccination, but do put pressure on individuals to be vaccinated, let alone implement widespread vaccine mandates. So currently, the dominant areas in which I've seen vaccine mandates are either in healthcare systems or in higher education. But for somebody to return to their banking job or their lawyer job, they're not required. And so we haven't culturally decided, in order to protect one another, that we're going to create that type of social pressure or mandate. It would be trickier because of all the implementation issues. But my impression is that, Israel and other countries have effectively implemented so-called vaccine passport systems. And so I think that they are feasible. We've just, for political reasons, chosen not to implement them. And then I think it's going to be a big question as to whether or not, we're going to let adults have a buy in the future, but require children to be vaccinated, which, part of the question will be about, whether children have a particular role in transmission. But that might be, so Tony, I'll come back to the principles, unjust to force children to be vaccinated for school entry against COVID if we're not equally going to require adults to be vaccinated.
Boy, it puts us as one heck of a pickle. Well,
I agree with that non-ethicist summary.
Yeah, yeah. I mean,
it's challenging. The Supreme Court, as Armand already pointed out, or not the Supreme Court, but local courts have started to chime in positively on this. And it's always frustrated me around school vaccinations that, Supreme Court law goes back more than 100 years around vaccination. And it's pretty clear. They support, when there's a compelling public health community interest, they support mandatory vaccination and have in the past. And that, that's the basis for a lot of our school vaccination laws, which have honestly been the cornerstone of the eradication of childhood diseases in the United States. They are one of the great public health successes in the last, 75 years in the United States, undoubtedly, along the way. And Armand, you do point out what is already today a very coherent dissonance in those laws from a public health and ethical point of view, in that they are purely focused on children when adults get a lot of those diseases. And interestingly, the diseases where adults would benefit a lot from kids being vaccinated, like flu, they're never really frequently included in mandatory vaccination laws across the United States. They always focus on the older diseases, and influenza in particular is included in almost none of them along the way. So there's a lot of dissonance already in the system, and the question of whether it's just to ask children to be vaccinated for this is an important one. And I feel like I'm being unethical in my difficulty, considering that I have no problem whatsoever with making sure all the kids are vaccinated. But I think that may be that I think I approach this from a very un-American point of view of the community rather than the individual. And, this is for me a community responsibility. And yet it's tied up in both the ethical and the American tradition. What's a more American tradition than autonomy and self-determination?
Yeah, there's an old joke where if everyone's saying we got to go right, I'll adjust it. If everyone's saying we got to go right, someone somewhere in America is going to say, I'm going left, purely because. But let me phrase the question a little differently. What about those that say measles, mumps, rubella, even flu has been tested over many, many years and has the safety has been established? What about people who say, I'm worried about this emergency use authorization for these vaccines that are brand new? I'd like them to be fully FDA approved for me to feel more comfortable giving them to my kids. And I find those discussions, I find that a reasonable thing to say, because even I have trouble parceling out what is the difference between emergency use authorization. How much more data has to be present to get full FDA approval? So what do you, we'll start with you, Andy, kick it out to Armand. What do you say to that?
Well, it's pretty clear that the companies have applied for full approval. So this is not that the companies don't want it. And that is in process at the FDA. Armand clearly knows more about vaccines than I am familiar with ethics, because he's already pointed out that we really consider that 6 to 8 week window of side effects from vaccines to be the most relevant window of it. We also have gathered an unbelievable amount of data in the last 18 months, from the beginning trials to, vaccinating 200 million people in the United States. We know a lot about these vaccines, and they do seem to be safe, and they do seem to be very, very, very effective. So I have to assume that based on these data, full authorization cannot be far away. Emergency use authorization is emergency use. I'm not fluent in the federal law for it, but it's a very sensible approach to say that the risk of not having a full data set on this allows us to be weighed against the benefit in a public health emergency, which is what the pandemic has been for 18 months as well. And so I think those decisions are very reasonable ones along the way. I really hope that the FDA is going to do the right thing soon and license these vaccines, given the massive amount of data that's collected. Sometimes you collect data over time because you don't have many data points to collect. We've collected probably the largest rapid deployment vaccine data set in history. And I think it's very positive and probably worthwhile for the FDA to approve.
Armand, same question.
I know that there is substantial anxiety about the pace of development of the vaccine, but it was my understanding that when the FDA announced the standards for approval of EUAs, that it actually, in some ways, ratcheted up the standards for the EUA in this case relative to other cases. So I think that should provide some degree of confidence about the EUAs. And then I would say in the long run, again, if people have concerns about the mRNA vaccine technology, they have other options in terms of other vaccine technologies. So my sense is that with the increasing supply of vaccines, if individuals are desiring to be vaccinated or are required to be vaccinated, they will potentially have choices and can exercise choices around their assessment of the relative risks and benefits.
That's very helpful. Now, this is kind of what I wanted to do with this episode. I wanted to talk about the infectious disease aspect of it, the ethics aspect, have a roundtable discussion about stuff we're seeing in the news, because our primary listeners at PHM from Pittsburgh are physicians and healthcare professionals who interact with the public daily, and all of us are getting bombarded, no matter what news channels you listen to, with information on this and different topics and different views. The LA Times article I brought up was an interesting perspective in that it brought up divisions within the medical community. I'll point out a lot of the articles they brought up were in medpage.com, which I don't read very often at all. So there are people who are saying we should slow this down. It sounds like the FDA approval process has slowed down. They initially were proposing for roughly fall and asked for more data from the companies, so they're pushing it back to early winter. It's an interesting discussion. Is there anything we did not, and we don't have much time, we didn't bring up that you all thought we should bring up? We'll start with you, Armand, and kick it out to Andy.
So I'll just briefly mention, Tony, because you highlighted the role of autonomy, the potential conflict between parental autonomy and adolescent autonomy. in particular, adolescents who wish to be vaccinated and parents who do not wish their adolescent to be vaccinated, and whether adolescents should have the right to consent to vaccination without parental consent or in spite of parental refusal, which ends up being a question about adolescents' medical decision-making capacity, and that I think that most adolescents are capable of understanding the risk benefits and alternatives to COVID vaccination, appreciating what that means for them and evaluating the risks and benefits and making a decision. But it is also then a question about the scope of parental authority in raising children and how to balance those things. And seeing some, different states have different age thresholds for medical decision making. And some states are looking at either authorizing adolescents to consent to vaccination or seeking to specifically prohibit them from consenting to vaccination, which I think will be an evolving question.
That will be interesting to see what happens to that. Andy, what about you?
I am fascinated by, I really am very focused as I look to the future on the battles that are going to occur over school vaccination laws, to twist your question a little bit, because I think that if I were to be the one in charge, I would try to go that route, because those mandatory vaccinations have overcome, for the most part, the vast majority of parental concerns about vaccines in an overwhelming way in the United States. So I'll be interested to see how that goes along the way. I just hope the FDA does the right thing sooner rather than later, because I think that will help move this discussion forward in a very powerful way. Adolescents are not my concern. I think we can get a lot of adolescents. I find that adolescents, when I counsel them, are really excited to get the vaccine most of the time. They're very friendly to it. But the younger school age children, we have to get those parents if we're going to vaccinate, and it's going to be a big battleground.
I think you're right. From my perspective, I will vaccinate my kids the moment they're able. They're under 12. So if that means anything to anybody, which I don't think it should, that's what I'll be doing. But this was great. I really wanted to try this as an idea, as a way to discuss topics from a different perspective. Armand, I can't thank you enough for being on the podcast. I really appreciate your time and expertise helping us with this.
Oh, you're quite welcome. Can I make one more point from a PHM perspective?
Yeah.
I think that part of the question is, well, why should hospitalists be concerned with this? And I would say that I think that there's increasing awareness that particularly adolescents have limited regular contact with the healthcare system, and that hospitalization may be a point of contact through which catching up or providing vaccination may be important. And so that hospitalists may be, over time, increasing the scope of what they see as within their ambit. I know at our institution, we're working with some of our continuity clinics to try to identify patients who are behind on their vaccine and use hospitalization as an opportunity to catch up. And I would say that the other part of it is that we care for many patients with complex chronic conditions. I think it'll be interesting to see over time which of those patients can't be effectively vaccinated. And I think that it's part of our advocacy for our patients who who are vaccinated, but the vaccine has a lower efficacy for them, and that advocating for them, for other people to be vaccinated to promote their health and well-being and their ability to broadly participate in society is another point that's important for hospitalists.
I could not agree more. The bulk of our patients are medically fragile patients who that vaccine either may not work, or because they're on immunosuppressants for other reasons, they can't get it. And those are the kids we are trying to protect. They're the ones I worry about the most. I couldn't agree more, Armand. Thank you.
Sure.
Andy, as always, thank you for being on the show. You're a wonderful guest. This ends our 3-part series with you. Thank you.
My goodness. You can take a break from me for a couple of years. I'm sure you're tired of it at this point. So, Armand, thank you. Armand, thank you too for helping me. I mean, this has been a great discussion to think through how we approach this we make decisions at the health system level, as we advise our schools, as I counsel parents, because, in the end, I think a parent who we counsel well and we can really bring along to a decision where they see benefit from this for their child is the best case scenario for me in this.
And I would say that I think that's the way that ethics works best, is in conversation with content experts. So Tony, I think it's a great format.
If you're listening, make sure to get your free CME from the University of Pittsburgh. Click on it, courtesy of the University of Pittsburgh. Thank you to Cincinnati Children's and as well for lending us your wonderful expert in Armand. And everybody have a great day.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.